Good morning. It's Wednesday, May the 18th, and I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome to Open Mics with Dr. Stites. Running a big city hospital like this one is like running a small city. It takes a warehouse full of supplies, like the ones you're looking at right now, to keep things running here. Everything you can think of, and a lot of things you never thought of, need to be on hand and ready to use at a moment's notice. But what happens when there's an interruption in the supply chain and suddenly vital medical supplies become hard to get? It's a problem that keeps hospital supply leaders awake at night, and it has throughout the COVID pandemic, as we've bounced around on this before, and one that the health system and other hospitals around the world are battling right now. I mean, we talked about masks, we talked about gowns, we talked about gloves, we talked about medicines to keep you stable in the ICU, but now we're talking about a critical worldwide shortage of contrast fluid that's used in CAT scans and in x-rays. We'll see how area hospitals are coping and what it means to the patients. We'll also look at the bigger picture of drug and supply shortage worldwide and find out what hospitals do to make sure that vital patient care can continue. And we're going to check in with Dr. Hawkinson today for our latest COVID numbers, and we're going to drill down into some of the COVID numbers today because there is a story to be told. So make sure to get your questions sent in to us on YouTube, Facebook, and the Medical News Network. You find those links right here on your screen. We've got a great panel of guests for you today. Our good friend, Dr. Raghu Adiga, the Chief Medical Officer and an infectious disease physician at Liberty Hospital, join us. It's a little tough sometimes because I get Hawkinson and Adiga teaming up on me, and we have to just watch for that, okay? We're going to be a little careful with that. Also in the studio is Dr. Phil Johnson, the Clinical Service Chief and Chair of Radiology here at the Health System, and Chris Lukes, Director of Pharmacy here at the Health System. And joining us live from our supply warehouse in Shawnee is Janie Ott, the Health System Vice President of Supply Chain. Janie has a lot of toys out there behind her. That's actually a real photo. So Dr. Johnson, we briefly touched on this last week, but explain what contrast is and how it's used.
Sure, Steve. Contrast is basically a fluid that contains iodine. It's a sterile fluid, and that fluid is then injected through an IV. And then as that fluid is circulating through the body, we then do a CT scan as the dye is percolating through the blood vessels and organs. And you can think of it as basically a dye that sort of lights things up, if you will, and it basically makes it easier to spot abnormalities. And this dye that we use is also used for interventional procedures, like cardiac catheterizations to treat strokes and other vascular conditions. So it's a very widely used dye. Hospitals use this dye every hour, every day throughout the world. To give some perspective, we do 75 million CT scans a year in the United States. So it's a major component of what we do in radiology.
So really it's helping keep people alive with either diagnosis or treatment. And because it helps kind of direct, for example, where you have to go break up a clot or where you have to go dilate a vessel or put a stent into something, right? And so if you can't see, then you can't do that.
Yeah, exactly, Steve. This, this shortage that we're dealing with relative to contrast dye is really just another example of global supply chain issues that we're struggling with and that the healthcare industry is dealt with. This was triggered by a lockdown in China related to COVID-19. The largest manufacturer of contrast dye has virtually their entire production of contrast dye within Shanghai, China. And when this lockdown occurred in late April, the factory had to shut down. It resulted in an 80% decrease in the contrast dye that's available. And that had a ripple effect across the world as hospitals scrambled to try to maintain their inventory of contrast, and it was very, very quickly exhausted in terms of that contrast availability. It resulted in the health systems having to develop conservation strategies for contrast dye. There are some cases where we can find alternative studies to evaluate patients around imaging using CT, using ultrasound, using MRI. However, there are scenarios where we absolutely have to have contrast dye in patients to establish a diagnosis or to guide therapy. And so The strategy for hospitals and health systems is to conserve as much contrast dye as available for those critically ill patients where we absolutely have to have the contrast dye to either establish a diagnosis and or to guide a life-saving or a limb-sparing procedure.
So that's a lot of work, and that's a lot of contrast, isn't it, if we're getting that much? So how long do you think we're going to have this shortage? I mean, I know we're already a few weeks into it.
Yeah, that's a great question, Steve. Fortunately, some of the restrictions that occurred in China related to the lockdown are starting to improve, and the company is starting to ramp back up production, but they're not up to 100% yet. And so this is expected to last for another 6 weeks.
Yeah, so that could be a long time. And just to say, this is all the result of that nasty little virus, SARS-CoV-2, causing COVID-19. It is the gift that keeps on giving. I'm ready for SARS Christmas to be over, though. How about you?
I am.
Yeah, that's time to be done. Okay, Dr. Adiga, all hospitals are feeling this crunch and are having to make some big adjustments. What's the shortage like up at Liberty Hospital?
It's the same. I mean, if there is something that we learned through the pandemic, it's how do we deal with supply chain issues, and this is one of them. So for us, we're at that Goldilocks size. We are not too large, we're not too small, so we can be a little more nimble. So when we heard about this 2 weeks ago, we kind of put together a group who came together with all the plans, even before all the recommendations were out from the radiology societies and everybody else. We had put those conservation methods in place. So currently, I think we are good for next 2 to 3 weeks. If we don't get any further supply, I think we should be able to manage. So we tweaked our protocols, we prioritized what we needed to do. And so I think we are good, but hopefully we will continue to get some supplies.
Yeah, well, we sure hope so. So, Phil, talk to us a little bit, and Chris, what have we done to limit the use of those drugs? How have you hit those conservation measures?
Yeah, so I think there's a number of things that we can do. First and foremost, if there are CT scans that are scheduled and these scans can be delayed for 6 weeks, then that's probably the most appropriate thing. The other strategies that we've used is to look at alternative imaging studies like an MRI or an ultrasound scan or a PET scan in patients. And in many cases, we're able to do a CT scan without contrast and still achieve the answer to the question that is being posed. Other strategies are reducing the amount of contrast dye that we're using for procedures, eliminating any waste. A lot of these contrast vials come in single-use applications, and we're able to split those doses and use the contrast. And so part of the strategy is also really to eliminate any waste of contrast and try to use every single drop possible. And we've been effective. We've reduced the amount of contrast that we've used over the last 2 weeks by 90%, which is pretty remarkable.
That's crazy. It makes you think there was a little waste in it. You think there was some waste in the system?
I definitely think there was some waste. I think a lot of good lessons learned here.
Yeah, you got to learn those lessons and take them away. Raghu, I see you shaking your head. Do you think maybe we've learned some lessons around this?
Absolutely. I mean, throughout the pandemic, we've learned a lot of things and how to be more effective, how to be, conserving certain things that we were wasting all the time. No question about that.
Excellent. Well, that is a big deal. Are you all having to prioritize patients? I mean, you mentioned that a little bit, Phil. And do you think there's any patient who we're not quite doing it as well as we would like?
Yeah, Steve, I think that's a great question, and that obviously is the big concern that everybody has, that whenever we sort of deviate from our typical approach to imaging, is there going to be some consequence that would harm a patient? The way we're going at this is our objective is to make sure that high quality imaging is maintained, that there isn't any drop in quality. And I want to also be clear that when we're evaluating these cases and we're triaging other solutions, we're looking at solutions that are equal to what we're currently doing. If there's a concern that we're going to miss something or that we're not providing high quality care, our threshold to give contrast is we're going to give the contrast dye. We can't afford to not establish an accurate diagnosis or to be able to guide a therapy appropriately. So I feel like we've been able to manage this pretty effectively with the other tools that we have in our toolbox.
So most healthcare organizations are not immune to drug shortages. In fact, 90% of hospitals say they've experienced at least one shortage in the past 6 months that affected patient safety. 99% said a shortage forced them to purchase a more expensive alternative. Chris, as director of pharmacy, this is nothing to you. Nothing new for you, right? No, it is something to you, though. It's not just not new to you. So talk to us about drug shortages. Why do we have them? How common are they? What's the future hold? And is this all due to the doggone COVID thing?
You know, it's not just due to COVID. We deal with shortages every day. I would say we are typically managing between 5 and 10 shortages that change something about how we have to prepare medications for patients. And that's at any given time. And so we're really fortunate here that we have a large team. We meet regularly about drug shortages with our pharmacy operations team. We meet actually 3 times a week to talk about shortages and all the different mitigation strategies. But our goal in pharmacy really is to never allow a drug shortage to affect the patient, right? And so we do everything we can to try to make sure that the patients and the providers don't have to do anything differently. And so we try to take on that as much as we can in pharmacy. And sometimes we're not able to do that, such as the contrast shortage.
You know, I remember when a few years ago, the hurricane that hit Puerto Rico and caused such devastation also wiped out, if I remember, some IV fluid plants. Is that right?
Absolutely. Our primary IV fluid supplier, one of their primary production facilities was in Puerto Rico, and they were shut down for 6 to 8 weeks due to a hurricane. And so in that market, you know, we use such a large volume of IV fluids in the hospital. When one supplier goes offline, the other suppliers just can't make up the difference. And so we had to get very creative with how we provided fluids to patients.
So what are some of the biggest shortages you've had to manage? We've said the IV fluid one. Have there been others?
Yeah, certainly the IV fluid one is the biggest one that comes to mind, and I think this contrast fluid or this contrast shortage will go to the top of the list. I think, you know, the shortages we deal with on a regular basis are often with IV medications. Those are the most common things that go on shortages, and that's due to just the complexity of producing a sterile medication for injection. And so we commonly see all kinds of different things: pain medications, antibiotics, medications for blood pressure, all kinds of different things.
You know, I was going to say, we got a patient right now in the hospital who needs some gentamicin. We can't get it because it's on short supply again. Exactly. And for some of my CF patients, that's a big deal because we mix it up and people can inhale it, and now she can't do it. And she doesn't tolerate the Tobro, but she tolerates gentamicin. So absolutely, those are struggles we all face. And I think it's become worse in the last few years. I think as people try to make the supply chain less redundant, shall we say, and not have as much stock, what ended up happening is we ended up seeing more shortages. Is that fair?
Absolutely. That is true. And so as we only have one manufacturer left of a medication, then sort of all of our eggs are in one basket. And so then when that manufacturer goes offline, we see a shortage. And so as you mentioned, there's just not a lot of redundancy in the system.
There isn't. It is. Okay, Janie. So you're the magical wizard for us. You're the VP of supply chain. Back at the beginning of this pandemic, you and I spent a few Friday and Saturday nights about midnight trying to find N95 masks. I remember those conversations, and there were some of these people trying to make a profit off of it, and some fly-by-night people selling masks that didn't really work. And you were a great support and a great help to us now. You have to be worried about more than just those drugs. Everything from baby wipes and baby formula now. To tongue depressors.
Right.
And you need a huge place to keep everything. I'm looking at the picture behind you. Jenny, it looks like Home Depot, only I'm just going to say it, it's cleaner and better organized. Tell us a little bit about what we're seeing in the warehouse behind you.
So we have everything. We have a lot of space. We have great shelving. And we have PPE. So Dr. Stites, that night we stayed up late looking for all these different things. We now have them in bulk at the warehouse. And exam gloves, I think, are what are right behind me. And, you know, that's been something that's been on shortage. And so we've been able to buy in bulk. We've been able to keep these things at the warehouse. And, you know, all of this is about keeping our patient in the center of everything we do. You know, we want to make sure they have the supplies they need, when they need them, how much they need. And our job is to make sure no one has to worry about that. We need to worry about that, but we don't want anyone else to worry about that. And so creating the warehouse was really a reason to, you know, support our teams and support our patients. So this is just what we needed to do to keep everyone safe.
Well, Janie, if I could bow down and kiss your feet right now, I would, because I so appreciate your great help. You found stuff when there wasn't stuff to find, and I really do remember those phone calls. I remember how late it was, and some of the people we dealt with. Well, I'm not sure they were always the most straightforward folks. It was a little shady there at times. And you always said, no, not that one, this one. And it turned out to be very true. So thank you for that. So you've talked a little bit about the purpose and function of the warehouse. Do we have things that we're worried about right now? I mean, I know the baby formula shortage is a big deal.
That is a big deal right now. It absolutely is. And so, of course, we're doing our due diligence to make sure that we're on top of that. But you know, Dr. Stites, we do that same due diligence with many products in a day's time. So there are back orders, there are recalls, there are shortages. And so our team is constantly securing supplies for the health system. And I'm going to quote Brian Zane. He is the director of the warehouse, an amazing individual. And one of the things he says is, my job is not to run out of anything. And he takes that to heart. And, you know, they move mountains so that we don't have to be without anything. So our claim to fame has been, we have not ran out of anything. We have had to make some substitutions, and we have not purchased any counterfeit product. And that's because of the amazing supply chain just knocking it out of the park every day. They're creative, they're innovative, they're adaptive, they're resourceful, all those wonderful things, and you know, they deliver. So it's been just inspirational to watch them. They're my heroes.
That's pretty cool. And Jane, if I come out there, can I drive the forklift around? I see it going behind you sometimes. I think that looks pretty exciting. I'd like to give it a give it a whirl. That looks like fun. And just to say,
that is the funnest thing.
It is.
The
I
two funnest things out here.
Yeah.
The forklift is really, really fun. And then we have this cool thing that spins a pallet and puts plastic wrap around it. That's the second coolest thing.
Okay, I'm ready to go.
We have all the fancy tools.
I want to see it. And one more question. I got a couple more questions, but one is, you know, there's a pretty big used car shortage. Do you have used cars in that warehouse? Any used cars?
Used cars.
Yes.
Okay, we are not, what is that place, Carvana? We're not that.
Okay.
But, you know,
well, that's fair.
You never know.
Okay. So you've talked now about the purpose of the function of the warehouse. Has the warehouse been a good investment for the health system? Because, you know, I don't think most people think hospitals have warehouses off-site where they're storing stuff. That sounds like Costco or whatever. Has this been a good investment for us?
There are not words to describe how important this investment is. You know, it is securing our supply chain for our health system, and we're a big play. And supplies go in every different direction. And so building a distribution center to house those large quantities and then distribute them out was just critical. And then it's also a part of a cost reduction strategy. You can buy in bulk and secure those lower prices, and that's also critical too. So multiple things that make this such a good investment. We've invested in people first and foremost, technology, the space, the shelving, and then just the inventory itself. And it's just crucial to making sure we have that secure foundation for the health system.
Pretty cool stuff. And don't forget the forklifts and the plastic platter spinners. That looks good. That looks pretty cool too. I'm coming out there too.
It is cool.
All right, so thank you so much, Jane. We're going to check with you and back with you in just a few moments. I want to turn now to Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. Hawkeye, what are the numbers like today here in the health system?
Yeah, in the health system, we have 4 active infections, 0 in the ICU, 0 on the ventilator, still 9 in that recovery period. So still numbers are holding steady as far as active infections staying in that low single digits. That's overall a good thing.
It is a good thing, but we know the numbers nationwide are kind of crawling up a little bit. And we're going to talk to Dr. Adega and Dr. Hawkinson now a little bit about some of that COVID. But first, the health officer in Johnson County posted this video yesterday. Dr. Joseph Lemaster says that among those who come for testing, the positivity rate is up to 17%. That's a lot higher than 3 or 4 there was. He adds the county is currently experiencing a rate of 168 cases per 100,000 people. I'm going to come back to that in just a moment, but that's a big deal. The other thing we know is that the Missouri SEWERSHED project monitors wastewater treatment plants across the state and showed several locations reporting an increase in viral load here in Kansas City. In Boston, I was reading last night that the amount of wastewater positive for COVID-19 is the same as it was at the peak of the Omicron crisis in January. Further, we believe that the positivity rate that is occurring in the community, it's probably the true community spread rate is between 5 and 10 times higher than that. So if we're at 100 per 100,000, the real number is probably 500,000 or even 1 million per 100. I mean, the numbers crawl up really rapidly because of the underreported nature. It's harder to get a COVID test, and you're doing them at home, and those aren't ever reported. So we think that's really going up. In just hours, the White House COVID-19 response team is set to hold a news conference on the growing COVID numbers. Among those set to be there, Dr. Anthony Fauci. He didn't ask me there today, but that's okay. Well, let's talk about, and first of all, see if there's any reporter questions, then we're going to continue our conversation. Nope. All right, so let's talk a little bit more now about supplies and COVID-19. But first, I want to show some of the slides that we put in for this part of the conversation. So this is an important discussion. You have to ask yourself, why is it we're doing so much better than we did before if the numbers are as high as they were in January? Even in Boston, where there's beginning to be some pressure on the hospitals for beds, the numbers aren't like they were in January. Why is that? I think this graph helps explain it. First of all, it shows you the whole length of that is 100%. And what it says is that 78% of people are vaccinated, 66% are fully vaccinated, and 31% are boosted. So that's showing a lot of people in the United States have some amount of vaccination. In addition, it's estimated between 60 and 70% of Americans have had some type of COVID. Yeah. And if you put vaccination and natural immunity together, you're going to do a little bit better. I'm going to turn for discussion to my colleagues here in just a moment, but first, go to the next slide. So this demonstrates what happens by age, and I think it's really important to note that those who are 65 and older, we talked a little bit about this yesterday, 95% have had 1 dose, and 91% have had at least 2 doses. I think that's one of the reasons we're so protected, Hawkeye, because a lot of the folks most at risk are more vaccinated.
Yeah, I think that's right. And also when we saw that new serological study, so a study looking at antibodies in the population, the CDC came out and said there were it's a massive proportion of adults who have had COVID. They have evidence that they've actually had infection. So I think that vaccination plus that infection is adding to that individual immunity, most important, though, to keep you out of the hospital.
If you go to the next slide, I think this is important as well. This is a graph of cases by state and territory. And what I want you to notice is that the numbers are going up rapidly. And remember, the real numbers are probably 5 to 10 times that, right? That's the real number because we don't do as much testing. If you look down below, you see the number of hospitalizations. They are starting to crawl up, and again, especially in the Northeast, there's beginning to be some pressures on hospitals. But the rise of that graph does not come anywhere close to matching the rise of the caseload, and it's not matching the rise of prior COVID waves. The best news is the number of deaths are still lagging. Next one. This just talks about how it's different by age. And again, those older at most at risk, and it just goes down by age. That should surprise. That's been the truth throughout the whole pandemic. It continues to be true. There's an important message here, though. If you're in an at-risk population, you're still in an at-risk population. And you need to think whether there's a public cry for masking, etc. Do I need to think about masking indoors or in large-scale crowds? In fact, in New York, they believe they're at the cusp of having to put a mask mandate back in place. Philadelphia already did. So just be thoughtful already. Make sure you take care of yourself. We're not saying we have to go to that right now here in the Midwest or here in Kansas City, although the Midwest is getting hit harder and harder. I think what we're trying to say is just beware of what's going on out there. There's a lot more community transmission. There are a lot more patients that are positive. If you're an at-risk person, just be thoughtful. Remember, the rules of infection control, they still keep you safe. Next slide. And this just talks a little bit more about the deaths and things like that we talked about just a moment ago. It just makes it a little larger scale to see. We go to the next slide. All right, this is an important slide, and I'm going to let Dr. Adiga take this because this is a different kind of heat map than what we usually show. Raghu, talk to us a little bit about what this one is saying to us.
Yeah, so you've got 2 maps there. One is full of green, one is full of red. So, but it is representing the same situation that we are in right now. So a few months back, all we were seeing was the heat map on the right side of you, that is the transmission map. So essentially that explains counties that have the level of transmission going on within the counties. So essentially there were two factors that were taken into account to give you whether the red or the high transmission rate or the different grades below that. So it is the number of people who are infected, new infections per 100,000 population for a week. So that's the number you're looking at. If you're more than 100, it goes to red. So this is what was being distributed to everybody. But all of a sudden, as you know, a month or 2 months back, CDC came up with a better plan just because that didn't necessarily tell us what to do a little bit better, especially with the hospitals being overwhelmed or not, and then even people with infections with minor symptoms being recognized within that population. So they came up with this community level, which takes into account how the hospitals are doing. So how is the hospital bed capacity that's available for how many COVID patients are admitted to the hospital, what percentage of beds are taken, and what percentage of patients with COVID are getting hospitalized. So taking that into account, they created this community level. So when you're looking at that map, that full of greenery, what I call the overwhelming greenery, gives people a level of comfort that, oh, we are okay. That's what bothers me a lot with the new map, that it doesn't reflect what's going on with the transmission. Yes, currently the hospitals are not overwhelmed, but potential for that is still there as the transmission is skyrocketing. That's the difference between the two maps.
Yeah, and indeed, we're seeing that already in the Northeast. Thoughts about that? Because I'm a little nervous about what that lag could be like, what it could mean.
Yeah, I mean, I think we could still be optimistic and hoping that we'll continue to have low amounts of hospital capacity affected. Again, I think it goes to all that we've said, and I think we can also draw inferences from the UK experience with their recent surge and the South Africa experience with their recent surge, where they didn't see that overwhelming issue with hospital capacity, even though they had a lot of infections in this last surge, or this BA4, BA5 surge in South Africa, and a BA2 surge in the UK as well.
It just looks to me like we have to be thankful for vaccination again. I think Paxlovid's making a big difference as well, and will continue to make a big difference, and natural immunity too. Dr. Adiga, what are the numbers like up in Liberty? Are they still staying low?
Yeah, we are actually very good now. We have only 3 patients in the hospital, and we had about 7 last week, but it did come down, and nobody's in ICU. Obviously, nobody's intubated. Another good thing is that it's been almost a month since we've had our last COVID death in the hospital, so I'm very happy about that.
That is good news.
Yeah.
And just to say, if you look at the national data, the ICU utilization is much lower, even in those areas where hospitals are beginning to crawl up in the Northeast.
Yeah, and I think we should also contrast, our current experience, or really the rest of the world's experience, with vaccine-induced immunity. We know some countries aren't as high as vaccination as others, but also this previous 2 years with natural infection and some immunity garnered from that infection and reinfection. And that is opposed to kind of what we are probably expecting and what we are seeing now in North Korea, which is a country that has been shut off really from COVID for the past 2 years. Now they are going to experience, and we can see what happens when you don't have that immunity, especially that safe immunity from vaccination. Also, they haven't had any really immunity from natural infection either. That is opposed to kind of what we are seeing now, as we have really talked about, and that is that immunity. The safest way is that vaccine-induced immunity, but also the infection and reinfection immunity as well.
I think it does make a huge difference. I think we should be very thankful. And go get your booster if you haven't got it. I had my booster on this program yesterday, and here I am.
Yeah.
My hair didn't just fall out because of the booster. I went bald for shave to save, so it's going to come back someday. But for right now, Phil Johnson's my twin. All right, do you think we're headed back to the same kind of COVID numbers we saw in the winter? Because I'm hoping we're not, just because of vaccination and immunity.
Yeah. And also, I think we're optimistic that we will not see that hospital capacity issue. The amount of people coming to the hospital or going to the ICU because of what we have just talked about. And remember, vaccinate, be up to date with your vaccinations. We know there will probably be new recommendations coming out for adults in additional dosing. We know that the FDA has approved the 5 to 11 dosing. Now we are waiting for Thursday's recommendation. We had a question yesterday about will it be available as soon as it's approved or authorized. We are waiting for the advisory committee's recommendations for getting those 5 to 11, their second dose. Or their third dose.
It's a booster.
It's a booster. It looks like it's going to be about at least 5 months from the first two. And then, of course, if you have symptoms, test early, get treated early with Paxlovid. All of those things are significantly going to reduce your risk of hospitalization.
And Dr. Ardiga, the rules of infection control.
Yep, they go wherever you go.
They go wherever you go, darn right. All right. Dr. Johnson, will the CT contrast shortage have an effect on health insurance for patients? Because I know that's got to be an issue if we're doing different kinds of tests, right? Doing MRI instead of a CT.
Yeah, that's a great question, Steve. And I think the important thing is that we have been communicating with the insurance payers, making them aware of what we're dealing with in terms of this contrast shortage and the need to look at alternative exams that are done. All of these studies are commonly done and they are covered by insurance, but they typically require prior authorization so that if a change is made, we will typically then notify the insurance company and get pre-approval to do the study. But because of the rapidity of this crisis, there just wasn't early on the bandwidth to make all of those changes right away. So we've done a number of things. First, we're documenting well in both the report and the medical record the need for changing the study and why it was done so that there's justification for the change in those cases where the scan was done prior to receiving prior authorization from the insurance companies. I think the other thing that now that we're sort of catching up with this, our scheduling people, our registration people, our medical staff are working with the insurance industries in getting pre-authorization in advance of these studies that are now being scheduled. So I think it has been a challenge. We've also sent communications to the insurance companies asking for them to loosen up, maybe there would be a way to say it, some of their restrictions in terms of changing studies that have been already pre-approved.
Janie, I know that historically, we've tried to do a little leaner job with trying to keep supplies around and even do some just-in-time sort of supply chain work. Where are we with that right now?
Right, so we've changed our strategy. So we had a LUM strategy, which is low unit of measure, and now we've gone to a bulk strategy. And so rather than just having supplies come into our facility for just what we need that day, now we buy the supplies in bulk. We don't have to worry about them every single day. We know that we have a stable supply chain that's going to provide that volume that we need to take care of patients.
Yeah, that does make a difference. Okay, Chris, is the pharmacy doing the same thing? Can we weather these up and down storms now better than we could have before?
Yeah, I think the biggest thing we've had to do is change our process. So, and I mentioned earlier, we're meeting regularly. We're also really fortunate. We have a dedicated team that just focuses on acquisition of medications, and so they're able to be really in tune with the market. They work very closely with our suppliers and also with manufacturers to try to get information about when these products may go on shortage, so that we can get started early with our mitigation strategies. We also try to buy bulk in critical medications that we just know we can't run out of.
So are you worried, is there a medicine out there, for example, that you're concerned about?
Not today. Unfortunately, we oftentimes don't have much heads up when these drug shortages are going to come. We know that there are certain drugs that we absolutely can't run out of, and so we have sort of an extra process around those. We also leverage warehouse space to sort of backstock those medications. But oftentimes we don't know about a shortage until the product just doesn't show up, and so it's really difficult to predict. We stock about 3,500 different medications, and so trying to predict which one of the 3,500 is next is pretty difficult.
Yeah, I can imagine that would be a big challenge. And we do get caught sometimes because you don't know what's all, because I think some of the drug companies don't go out and say, hey, we're running a little short. They just say, hey, we're out of it. And you don't always know until the last minute like that. So is this the greatest pharmaceutical challenge you've lived through? Now, you look very young, but I'm going to assume you've been doing this for a while. You're a little gray around the temple.
I think the shortage that we talked about earlier, the Puerto Rico shortage, was a little bit more difficult, really because it impacted all of our patients. It impacted every patient in the ICU, every patient getting IV fluids, every patient that got an IV antibiotic. That was probably the most difficult one. COVID was certainly very difficult. But this is definitely one of the bigger challenges and one that has had the most impact on our patients.
So Janie, back at the warehouse, you got some pretty cool things going on. Again, we got the cool forklift, we got the cool plastic wrapper dealy mahiggy. How many employees work there with you?
We have 15 employees here, and they are just doing such a great job. Yeah, they're amazing. They're some of my favorite people.
That's awesome. And I know you've said before, the warehouse is the foundation of the supply chain. How is that going to help us sustain the future of our supply chain? Is it just going to have storage, or there's got to be a mindset that goes along with that?
There is very much a mindset that goes along with it. And, securing your supply chain is really elementary. You have to look at a stable future. So it's just like anything else in the world. You have to make sure you have supplies to do what you need to do every single day. And so putting the warehouse in place and optimizing efficiencies with technology, all of that is so that physicians, clinicians, patients' family, our guests, we should be invisible to them. They should just know that we have it and we're going to take great care of them. And without the warehouse, there is a constant worry, will we be able to get something? Are we going to show up and try to provide care and not have something? And so being able to strategically plan is crucial, and the warehouse is just a crucial piece of that.
That's a big deal. My household, I do the grocery shopping, and I like to go out, and I like a lot of supplies, and my wife sometimes makes fun of me about the supplies, especially the dried cherry supply I might have, because it is a crisis in our household when we run out of dried cherries. I mean, how do you survive without that? Jess, let's see what questions you got out in the community today.
Well, good morning. The first one is for Janie. Ruth Ellen wants to know, is the location and security a high priority for the medical warehouse? I sure hope it is, she says.
Absolutely. And we have a very secure location. Of course, we have very high-tech technology that helps with that. And we're in a very private area. And so security is crucial, and that's very much at the top of our list, and that's a great question. So thanks for sending that in.
Yeah,
Janie, secret. They told me I couldn't tell your location today, and I said, that's fine, because I don't even really know where the heck it is.
Yeah,
that's exactly right. Not very many people know the address. Yeah.
But I'm coming for the forklift. Go ahead. Sorry, Jess.
I know. We're not even privy to that information, so that's how top secret it is. Kelly wants to know also, Janie, is this typical with other health systems? Do all hospitals have this type of supply on hand close by, or is this pretty rare?
So I think that the large organizations are taking on a warehouse strategy. For smaller organizations, it's probably not a strategy they can take on. And so the University of Kansas is a very, very large health system. And so this was the primary strategy to secure our future. But the size of the organization does make a difference in what strategy you pursue for a supply chain.
And I think one of the things we'd say, though, Jenny, is there are some other groups out there that try to help the smaller hospitals by sort of doing a co-op approach so that they can have their stock. They may not have their own warehouse, but they're really sort of a co-op with other groups to have a warehouse. Is that fair?
Absolutely, yes. And we have an affiliate network here at the University of Kansas, and we help our affiliate network. And so, it's more than just about the University of Kansas, it's about our partners as well. So, yes, we all collaborate as a supply chain.
Yeah, and I'm guessing, Dr. Adiga, you guys have a cooperative partnership too for supply chain for Liberty.
Yes, we do. We have our own storage areas within the hospital, basement area, as well as on campus, some other locations where we do store. Not a large warehouse like what you guys have. And then, of course, we do have co-ops that help us.
Yep. Jess.
Question from Joe Ellen is, are there companies in the U.S. that produce the dye, and that way a company could pivot and produce it?
Yeah, so production of any pharmaceutical, including contrast, is a really complicated process and has to be, that process has to be approved by the FDA. And so it's really difficult for companies to just pivot. And so in this particular case, there's really only 3 different manufacturers of this type of contrast dye. And so for another company to take that on would be really more than a year process to get that set up, and certainly we don't expect the shortage to last that long.
And just to say, we have to remember that the FDA doesn't only do the drug, whether it's safety and efficacious, they actually go and look at the manufacturing process to see if it's safe, that they make sure that there's no contaminants or biological issues or microbiological issues with the different drugs they make. And so the FDA does actually a really good job of making sure that the pharmaceuticals industry is a safe industry.
Absolutely.
You may have mentioned this earlier, but Joellen wants to know, is there a shelf life for the contrast dye? Is it refrigerated? How is it stored?
Yeah, so this particular dye is stored at room temperature, and it does have a long shelf life until it is opened. And then once the product is opened and we start using it, we have to use it really within the hour for the most part.
How long can it stay on the shelf, Chris?
Well over a year typically. So we typically try to buy product that has more than at least a year of expiration dating, which allows us to have adequate supply on hand to weather things like this.
And Mary wants to know, if notified that your CT scan will now be without contrast because of the shortage, will the doctor notify me if I should delay the procedure until it's then available?
Phil, what do you think?
Yeah, we're reaching out to the referring physician. So any scans that have been scheduled, the list of those procedures are being given to the referring providers, and they're able to review those and see if the scan should be done without contrast or if it should be done with a different modality or if it should be rescheduled for a later time. If the patient has not heard from their physician and he or she has questions about it, I would encourage them to reach out to their physician.
I know I have a patient right now who has had some trouble with recurrent pancreatitis, and his doubts are relatively mild, but he often has to come in the hospital. And so he needs a procedure where we put some dye into his pancreas to figure out where the issue is, and we've delayed it till July when we think we have more contrast because he's stable, and we want to save that dye for that patient who comes in with a heart attack or stroke, because that really has to be the priority. Those kind of interventional things or trauma that we're trying to look at or whatever it may be, we got to be thoughtful about that right now. But there is going to be a rush on it come July because we've had to delay a few things.
So, Dr. Stites, Pamela, Michael, and Adele have some concerns this morning, so I'm going to kind of combine their question. But Michael says, I think we're going to have another third COVID surge during the next several years. Maybe less painful, he thinks, than the past waves, but still concerning. Wants you to speak about that. And then Adele is concerned that this new surge will come and there'll be new variants and the vaccine will not protect against it. So just, can you address these concerns and what your thoughts are?
And I'll call on Hawk and Dr. Adega here in just a moment, because I think there's no question that we're going to have more. So we're in a surge right now. There is a surge going on. Yeah. It's just because of immunity and because of vaccination and because of Paxlovid. I think people are doing better with this one than they normally have. Had we not had vaccination, had we not had immunity, we didn't have Paxlovid, I think we'd look like North Korea and China, where they're seeing a lot more hospitalization and more death. The question then becomes, how many, first of all, I think we've already had, this is probably our 4th or 5th wave, it depends on how you count. And then, so I think we're going to have, this is going to continue to roll through. The question is going to be, how will we fare with those other variants that come along? And they've clearly trended to become more transmissible. The challenge is going to be, will they avoid immunization or natural immunity or Paxlovid and cause more hospitalization and death? That's what I think the focus is on. And I don't really believe there's a way to know that right now, Hawk. Thoughts?
Yeah, no, I think, as you said, there probably have been, this might be the 4th or 5th surge.
It's a lot.
That's true. We do expect more. I mean, I think there are some experts who, things aren't really going to be as normal, until maybe mid-2024 or late 2023. But does that mean that we will see the immense hospitalizations and death? No, and I think we have to owe that to vaccination vaccination immunity, and then of course infection and reinfection immunity, and that individual immune response that you get. Will the variants be able to evade our immune response? Well, certainly we know the vaccination was not really meant to protect against infection. What it was meant to do is protect against hospitalization, severe disease, and death. And the vaccines that we have right now have proven and shown that they can do that. Why is that? Probably because of the T cell immunity, those areas on the spike that don't change as much. And so we do gain immune response from that. And because of that, I continue to be optimistic that right now there won't be evasion of that vaccine immunity. But we also know that vaccines are still being developed in anticipation of other variants as well. So overall, I'm going to be optimistic that we are going to continue to see low rates of hospitalization and death compared to what we have seen in the past. And we'll see what Dr. Adiga has to say.
Very good. What are your thoughts, Dr. Adiga?
No, I agree. I think the numbers of new infections will continue to rise. The virus is evolving very rapidly, and there is some evidence of it escaping the immunity from past infections and vaccines, but not to the degree of losing, your immunity to be seriously ill or hospitalized at this stage. Having said that, I do believe this is turning more and more into an illness of those who are very elderly and people who have a poor immune system because they cannot really build good immune response to vaccines or prior infections. So those are the people who really need to be taking care of themselves, really need to be extremely careful. Those who care for them, who can bring it to them, I think needs to be continuing to be careful. But I do not expect the level of hospitalizations and deaths that we saw in January. But, nobody really knows. Beyond 2 to 3 months, it's going to be really hard to predict what the virus is going to do. It's evolving very rapidly. And we need to continue the science. We need to really fund our research into newer vaccines and, other methods to keep people healthy.
All right, Jess.
On that note, the last question is going to come from Gene, and he wants to know the fact that New York is reinstating masks indoors. What is that telling us about what we should be doing?
Yeah, I think it's early to think about that here. New York's on a higher part of that surge, and I think they're thinking about putting in the mask mandate on the indoors. They've said it's a high level community transmission in New York City. At least as when I got up this morning and read things about 6 a.m., I hadn't seen that they had decided to put on a mask mandate, so maybe it's changed since then. But what I think is happening is that we are learning as we go. We said we build the airplane while we fly it. Right now, the CDC has said it's going to be hospitalizations that really inform our guidance, because we're not doing as much testing. We're not even reporting on as much wastewater as we used to. So it's harder to know what's going on at ground level. You have to kind of interpret what you're seeing from like the health departments, et cetera. It's going to be the hospitalization account. And so far here in the Midwest, we're not seeing a pop in hospitalizations, not in the Kansas City metropolitan area. I wouldn't make a change right now. But I think Hawkeye and Raghu, I want to turn to you and get your thoughts. Yeah. I think that could come if we start seeing the numbers begin to crawl up for hospitals, as they did in Boston, as they did in Philly, as they are in New York City. Thoughts?
Yeah, I'll start. So I think that is important. I think even as we heard in that Johnson County video there with Dr. LeMaster, Johnson County Health Department still recommends masks. And so I think mask mandates, we've seen a lot of non-medical decisions against mask mandates, public health mandates for one reason or another. It is not based on medicine. It is not based on public health, but other reasons, and we know there are other reasons that go into those decisions that are made at the county level or the leadership level. So, medically and public health, masks are still fully recommended in those spaces where you can't separate from people. If you're not outdoors doing things of that nature, we know that is true whether you are flying or riding a bus or in a small area with a group of people. Medically and public health-wise, masks are still recommended to do that, especially if you are high risk. That will help reduce your risk of infection when doing that. And so I think we have to understand that. Other few final thoughts is that, we know the virus continues to circulate. You can do as much as you can do to protect yourself, and that is be vaccinated, be up to date with your vaccines. We know that we are waiting for recommendations for those children 5 to 11 and their boosters. That should come out fairly soon. In addition, if you have symptoms, test early and get treated with Paxlovid early, or especially if you're in that high-risk category for going to the hospital. All of those things will help reduce your risk of coming here to the hospital, of going to the ICU and having that severe disease.
Dr. Adiga, thoughts?
Yeah, I agree with everything that he said. And I think everyone has to make their own individual risk assessment, where they are at and what their risks are, and use a tight-fitting mask in the circumstances that we need to. And I also want to add to that early testing. It's so important to get the Paxlovid early enough, so have the tests available if you are high risk at home. And federal government has actually just yesterday released that you can get 8 more new tests free if you go to their website and order them. So stock up on those.
Yeah, that I think is really good advice. Well, Dr. Adiga, what are your final thoughts today?
Yeah, I mean, I think just as we said all along, we are doing well. We continue to do well in terms of our prevention strategies. Follow the infection control guidelines and look at your situations. Get vaccinated or get boosted. That's all I can say right now.
It's good, and thank you for being on our program today. It is always a pleasure to have you. Phil Johnson, my twin. Final thoughts.
I think this, we're learning a lot with this pandemic, and a lot of lessons learned. I think with the contrast dye shortage that we're going to get through this. The production is already ramping up, and I think by the end of June we should be through most of it.
Yeah. Fingers crossed, man. Fingers crossed. Chris Lutz. Luke's, God, I did it again. Chris Lutz.
All right.
I'm going to rehearse that.
I think I'm optimistic as well that we're going to get through this, and I'm really proud of the collaboration our teams have shown. Both, I'm proud of the team in the pharmacy and being able to source, and the collaboration with our radiology partners to find a solution to this that minimizes the impact on patients as much as possible.
It is about that partnership. Jenny Ott.
It's all good at the warehouse. So I would just say, we're in it for the long haul. We're making decisions for the long haul, and we got this. We're good.
All right. Well, you're good until I come out and start driving that forklift. Doc Cock, final thoughts.
That was it. Again, I think vaccinate, be up to date. We'll wait for the recommendations on the children's 5 to 11 booster. Test early. If you have symptoms, get treated with Paxlovid. And again, our biggest concern, the reason for the vaccines is to help prevent hospitalization, severe disease, and death. Our biggest concern is to keep you healthy, keep you out of the hospital. Doing those things will help keep you out of the hospital.
I'm going to go back to the question that was asked earlier. Should we put masks back on? That's a personal decision, and it's an important decision. Remember, the rules that we've said it once, we've said it 1,000 times, at least, just in the last week. The rules of infection prevention and control keep you safe, and they travel with you wherever you go. And if they will continue to keep you safe every day going forward. If you use your own common sense combined with the faith, hope, and science that has gotten us to such a revolutionary point in our fight against COVID, use that common sense, put a mask on if you need it, and watch the numbers because I suspect it's coming back. All right, thanks for being with us today. Don't forget, you can catch our shows anytime by logging on to our Facebook page or YouTube channel. We'll be back tomorrow with the Morning Medical Update. Have a great day, and remember, stay safe out there.
Coming up tomorrow on the Morning Medical Update. Thousands of people in the metro facing breathing problems and brain fog daily due to COVID. And many long haulers don't have anyone to talk to until now. I'm Jessica Lovell, the organization giving them a voice and advice. Thursday at 8 on these social media channels. On the next All Things Heart.
As far as my profile goes, I'm very happy.
How does this before and after save this man's heart? We answer that and more on the importance of a good night's rest. Thursday at 10.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.